Hi, everybody. Karen Anderson here with Aortic Hope for our live Q&A with Dr. Kristin Watson. We're so excited to have her here again, especially during Aortic Disease Awareness Month. So do me a favor, please click like, click subscribe, and click that bell because this is just the first live event of the month. We have a lot of live events this month, a lot of information to cover. So do that. And then when we're done, I'm going to tell you to do it again and then to share it because this is great information, even for people who might not have aortic disease, but might be on different classifications of these drugs. It's really very informative to understand what you're taking, why, et cetera, et cetera. So hi, thanks again for coming and joining us. Do appreciate it.
Thanks for having me back. I very much enjoy it.
Why don't you tell everybody a little bit about yourself before we jump right into your presentation, which looks like it's fancy and new, and I don't know if it's been updated, but I'm really excited for the information.
Sure. So my name is Kristin Watson. I have been a pharmacist for quite some time. My college, where I went to pharmacy school, has even changed names like 4 times since I graduated from there. So I'm a pharmacist. I am board certified in cardiology, and I also have a master's in palliative care, which I recently earned at the University of Maryland. And so my practice is both in inpatient internal medicine as well as outpatient cardiology and inpatient cardiology. So I kind of come from all those different perspectives. So getting a little understanding what you guys, not necessarily in your shoes, but being able to see the experiences that you may have when you're in the hospital or when you're clinic setting, and hopefully can address questions both those ways or anything that comes up in terms of your medications today.
Let me just say, I didn't even know that a pharmacist could do all of that and be involved in all those areas. And I would venture to say not many other people did either. I just, we're exposed to our pharmacist at our local drugstore or a specialty pharmacy, and that's what they do. So I find it so fascinating, all of the different areas that you have your hands in, and congratulations to you on that new master's degree. That's awesome. I don't know how you have the time with life and kids and soccer and Lord knows whatever else it is that you're doing, but you seem to have found the time. So that's awesome.
Yeah, it's a great experience. It was a life changer for sure.
Wonderful. All right, well, let's get into this because I'm really excited to have an opportunity to share with everybody this presentation, which we have updated on our resources page, and give everybody a chance to really learn a lot about the typical medications that are used for aortic disease patients. We've talked a lot about, we do talk a lot about aneurysms, dissections. We're really going to start to branch off in a conversation tomorrow about some arrhythmia issues. So I know that we touch upon that a little bit here as well. And maybe in the future, we'll expand into that since so many patients are starting to have issues. But the heat of the summer, we've got some water, diuretic, LASIK type pills to go over. And I always love when you talk about smoking cessation because we know that's so challenging, but it's so incredibly important. So I'm going to hand this off to you, and I'm going to mute myself until I have a question or I want to interject a thought. I'm going to let you take it away.
Awesome. All right. Well, let's see. Replace. Hold on, guys. Oh, here it comes. So we're like Karen said, we're going to go over a few different medications. So I'm going to primarily be focusing on things that can be used for lowering blood pressure, which we know is so important in folks with aortic disease. We're going to talk about some medications that can help lower heart rate, which we know helps prevent extra strain on the heart in folks who have aortic disease. And some of those medications, as was alluded to, can be used for some heart rhythm issues as well. And so as I go along, you can feel free to drop questions in the chat. I may not get to them till later in the Q&A section, but Karen will always, if there's points of clarification, she definitely is super helpful and will speak up and ask those things as we go along. And so some of the drugs that you will maybe cover tomorrow with the arrhythmia issues, I won't, like blood thinners and other medications used for those. I won't get to those, but we'll be more than happy to come back and cover that in the future if that would be of use to this group. So we're going to start off. Oh, I wonder, can you see my whole slide here on the screen? It might just be my section. Can you see my whole slide, Karen?
That's a Josh question. I see it cut off a little bit down after perindopril. I don't know if I said that right, but so I don't know if you have to move your cursor to make that go up, but that might just be my view.
Karen sees what we see as well.
Okay. So
You
it's a
do?
little cut
Okay.
off.
I
Whatever's
see the
underneath it, I think
whole
is a Q.
slide. Yeah, I see the whole slide here in one way. Oh, bugger ruggers. Okay. Well, we're gonna start the things
I've never, that's like saying whoops-a-daisies. I don't even know. I'm going to write that down. I've never heard that saying before. Are you from Maryland? Like, where did that come out of? What hat?
I grew up in Philadelphia with a mother who was a kindergarten teacher. So you can
Okay.
imagine all the things that I have possibly, oh, that's making it worse. Okay. Well, we're going to figure this out. 'Cause it's
Do
so
you have
bad.
can you use your, can you move the slide up or down on your screen? I'm just wondering.
Just
If not,
you,
just read what's on the bottom that we might, I
and then
think we're
I'll
only
just
missing
say,
one word.
yeah. So the first group of medications we're going to talk about, and a lot of these drugs, thankfully, really all the drugs here, and a lot of the drugs we use for patients who have aortic disease are medications who have been on the market for a very long period of time. And so we have a lot of experience in using these medications. We are well versed in side effects that happen and how, and if they do happen, how to manage those. So the first group of medications we're going to talk about are what are called our ACE or angiotensin converting enzyme inhibitors. This or the drugs on the next slide are typically when we're thinking about something to control blood pressure in aortic disease or other cardiac conditions. It's often one of the first classes of medications we go with. The vast majority of these drugs, if you're on one of these, the generic version is available. They're on the $4 list if cost ever gets to be prohibitive with the one that you may be on and what your insurer is covering. But these medications, because all the ones covered in this presentation have been on the market for a long period of time, we're fortunate that the cost tends to be lower compared to a lot of our other medications. So these medications can easily be identified. Their generic name ends with Pearl. So these medications lower blood pressure. The most common side effect that people will get, and it's only up to about 10%, is a dry cough. So it's this dry hacking cough. And I always will say, or if somebody reports that to us in our practice, it's the partner, the spouse, the child who is reporting the cough versus be bothersome to the patient. If this dry cough does develop with this medication, it can happen anytime during therapy. The good thing is once you stop the medication, that cough is gone within a few days. Pretty much the next bullet point in terms of side effects, dizziness, lightheadedness, that can come with most of the medications that we have listed here. So anytime you are going to be, so I'm not going to cover it for each of the different drugs as it comes up, but anytime you're starting a new medication that can impact blood pressure, that can impact your heart rate or your pulse, you want to take care in when you're changing position. So going from lying down to seated to standing, just to let the body adjust to the effects of these medications. So giving yourself, when you wake up in the morning, sit on the side of the bed for just a couple minutes, then get up, get standing, and get on with your day. One thing that can happen with this medication class, very rare, it's less than 0.1%, but folks can develop what is called angioedema. So that is lip, tongue, throat swelling can happen. If this happens with any time you develop lip, tongue, or throat swelling, you have difficulty swallowing, it doesn't matter what medication you may or may not be on. That is always a medical emergency and you need to get seen urgently. And I would suggest going to an emergency room to be treated for that. These medications, when they get started, blood pressure lowering effects are going to be seen within a couple days. So typically once they're started, your provider may be having you check your blood pressures at home. And if you're checking your blood pressure at home, please make sure that your provider goes over with you what are the correct steps for checking blood pressure. And Karen, I can give you a great infographic from the American Heart Association on checking blood pressures at home, because there's a lot of missteps that happen, both in the provider's office and then at home, and keeping log of that, because they're going to be your most accurate blood pressures. And what we're going to rely on in our clinic practices to use those blood pressure readings from home, for the most part, to make those adjustments in therapy. Now, and then your provider will often with this medication class is going to be, and many of the other ones here, you'll be getting routine blood work. It really depends upon, everybody is individualized, but at least twice a year, you'll be getting blood work to monitor your kidney and your potassium levels with this medication. So the cousin, I like to say, to the ACE inhibitors are what called our ARBs, or our angiotensin II receptor blockers. These medications work pretty similarly to that last class of medications, and the agents in this group, the most common one we see in the aortic population is typically losartan, candesartan, and then later down on the list, valsartan might be cut off for you, are the most common ones we just see prescribed because they've been on the market long enough. Other ones are perfectly acceptable to use. We consider them all equally efficacious. When we think of side effects with this, like I talked about that dry hacking cough, if you're on maybe something called lisinopril in that prior group that we spoke about, if you get that cough, your provider will switch you over to this medication class. And if it is due to that drug, that cough will go away. It will resolve and you will not have it come back with this medication class. That lip, tongue, throat swelling that we talked about, while it is listed as a possibility with this medication class, it is very unlikely to happen with this drug. But again, lip, tongue, throat swelling, I don't care what you're taking. If that occurs, you need to seek medical attention emergently, because sometimes it's a lot of detective work we need to play to figure out what the potential cause may be.
I have a quick question before you go into beta blocker. So I had heard that the ARBs, or specifically losartan, is sometimes used because it increases the flexibility of a vessel. Is that accurate?
So there, in people with aortic disease, losartan just happens to be that the one is most commonly studied in that patient population. Others have just been studied in other conditions. We really consider them all to be equally efficacious because we know that they give the same blood pressure lowering effect. A lot of times, though, they'll do some studies. They'll say, oh, this drug looks really good at changing in the blood vessel wall. But when it translates into what outcomes we see for patients, so the lower risk of worsening dissection or something else, a lot of that probably comes down to blood pressure lowering. So we really consider them all considered equal, especially too, because sometimes what drug you can get in a medication class can be driven by what your formulary what your drug your formulary may be. So if you're on you hear somebody with aortic disease on losartan, but you're getting candesartan, that would not give me pause for concern. It's simply it's probably the formularies, and I always say, like, where you train as a healthcare provider often dictates which drug in a class you tend to go with for whatever reason. But fortunately, when we think about medications across these cardiac medications that we have covered here, except when we talk a little bit in another class about differences in side effect profiles, we don't really have any good evidence, really robust evidence to say that one drug in a class is any different than the other, if that's helpful.
Okay, and is there a specific reason why a physician would say, okay, you have high blood pressure issues? Do you know why they would put you on the prils versus the ARBs versus a beta blocker? Is there specific reasoning? Do they have different mechanisms to them? And is there different things that happen that affect your heart and your blood pressure differently?
Yeah, so when we start somebody off who has high blood pressure, a lot of us tend to go with people who have underlying anything related to the vascular system. We tend to often go with an ACE inhibitor or the ARB, just because that's where our most robust data is. But others may feel more comfortable for whatever reason about a person. And sometimes there's things about kidney function. There's so many variables at play that they may start with a different class that we talk later on. And so there's not necessarily always, or sometimes we're lucky when it comes to high blood pressure. We have a lot of different first line options for individuals. And then we can get into what other conditions may be here. What else might be going on for the patient that we can really pick and choose what might be the best option. Many people who do have high blood pressure and have known disease, be it they've had a stent placed in the heart, they have aortic disease. We oftentimes see for a lot of people, many people in America need at least two blood pressure lowering medications. So it's very common, especially in aortic disease, that you're going to see people that someone might be on two medications to lower their blood pressure. In addition to these next two classes of medications, one or both to help lower the heart rate. So it's really, while we have some good guidance and good data to help us drive, there is a little bit of variability that we see in practices, just because when we get down to that individual level for a patient, sometimes we may have a preference on one medication over another, if that helps. So the next group of drugs that we're going to talk about, beta blockers, in addition to those first one of the two classes that we just talked about, beta blockers, their biggest role in people who have aortic disease is to help lower the heart rate. We know if the heart rate is high, in addition to so we have high blood pressure is not good for aortic disease because it's putting more strain. Too high of a heart rate we don't like as well, because that's also putting strain on the aorta. So goal is to keep the heart rate on the lower end. So many people, the goal is to try to get to a resting heart rate about 60. But again, that is very variable. Karen may feel fine with a heart rate of getting a resting heart rate of 60. I might feel terrible at a heart rate of 60, so mine might be a little bit higher. So everything is very dependent and gets to be patient-centered, even though we have these general classes. The most common agents in this group we tend to see prescribed is either carvedilol, it has two different brand names, or one of the metoprolols. Now, somebody might start off with a medication in this class, like maybe you're on carvedilol, and we'll talk about side effects. It's just not working for you. Your provider is most likely, and we have good evidence to show, if one medication in this class isn't working for you, let's try one that works on a little bit differently. And so that a patient may tolerate that a little bit better. But we know these drugs are so important that we're often going to try to, if it doesn't work at first, try another come back and try another avenue for individuals. So what are those side effects that can kind of make people say, whoa, this isn't working? When these medication classes are started, people can experience a little bit more fatigue. Now, many of you, when you get diagnosed with aortic disease, it's not a pleasant experience, right? Something serious has happened to you. You have a new diagnosis, which in itself can be overwhelming and make you feel tired. There's so many emotions at play there at times. But people, as you are on a beta blocker, as you are on it for a few weeks, you tend to get back to your normal self. Some people, that does not happen. The vast majority get back to feeling better. But if you're still feeling sluggish, your provider may switch you to another medication in this class to see if you respond a little bit differently. You'll see sexual dysfunction listed here. That really is focusing on erectile dysfunction. I do put that in here because I talk to my patients about, erectile dysfunction male patients is very common in people who have conditions that affect the vasculature system. So the aortic disease, the blood vessels in the heart, and other medical conditions. So we have drugs that treat erectile dysfunction, but we don't have good drugs to treat beta blockers. So sometimes to switch out for the beta blocker. So sometimes while the drug may be associated with it, maybe make things a little bit worse, the best discussion is to have with your provider to figure out what's the best option for you. Do we try to treat erectile dysfunction or switch agents? For my folks who may be on insulin therapy, it's really important to be aware of what signs of low blood sugar that you may experience. For people who are on a beta blocker and use a medication that can really drop blood sugar, which is typically one of the few that, the one that we most commonly use that can do that is insulin therapy. And so what will you patients, if they're on a beta blocker and their blood sugar is getting too low, they'll only notice sweating with that. So there's reasons we do other forms of monitoring in individuals. And then other medical conditions, such as certain forms of lung disease and in people who have heart failure, if the dose is added on, maybe too high of a dose or too quickly added, you may notice some worsening shortness of breath. And you want to report that to your provider because they're going to most likely want to make some dose adjustments for you. And with this medication and any of the medications, with the except, please do not stop any of these medications without guidance of your provider, because we do not want your blood pressures rising quickly, your heart rate rising. And if the side effects, well, it could be a side effect of the drug, it could be a sign of something else going on. So we want to make sure that you're getting a thorough assessment by your provider before making any changes.
Have you heard about side effects with beta blockers to include like brain fog? Because I can't tell you how many patients, well, first of all, just about everybody that ends up taking metoprolol, I can't even say it, complain about having fatigue, but also having some degree of confusion sometimes in brain fog. They're so tired with that or labetalol when they first come out of the hospital. And I'm sure some of it also has to do with having had surgery or an emergent event. But it's almost unbearable. And I'm glad that you mentioned that you should have that conversation with your physician, because you can switch to a different drug in these classifications and feel completely different on something else. And I will tell you firsthand, as someone who came out of the hospital on 900 milligrams of labetalol in a day, I can remember driving and then I don't remember why I was going or even how to get home, because then it creates anxiety and would make things worse. And I slept most of the time in my days while I was on that. And as soon as I made the switch to nebivolol or Bistolic, for me, everything changed. It was like someone turned the light bulb on and I woke right up. And it wasn't an overnight. It took maybe about a week or two, but the difference was incredible. And I'm just so happy that someone had said to me, tell your doctor. You actually might have to be the one to initiate that conversation to say, this is how I've been feeling and I've been tracking it. Here's also my numbers, but I'm not feeling well and I'm not having a quality of life, and let them go ahead and take a look at possibly making switches for you. But like Kristin said, do not stop and make a decision on your own. Tell somebody when you're not feeling well.
Yeah. And I will say again, these medications that we're covering are among the most top, like a medication for most of these classes are in our top 100 drugs used in the United States. They have been studied in tens of hundreds of thousands of people. So the risk of fatigue with these medications, and I see people, pretty much everybody I see in my clinic is on beta blocker therapy. The likelihood is low, but it is still there. And again, there are so many other things that can happen. There can be blood loss from surgery that can make you feel fatigued. There can be loss of sleep, but it definitely can have that effect on an individual. It can be dose dependent. So there's really making sure that your provider is going through and kind of assessing things to figure out and we like to make one change at a time to figure out what's going on. But definitely you have to speak up. And I always tell people that I care for, if you feel somebody's not listening to what you are feeling and what your thoughts are on a medication, is that the right provider for you to see your questions that you have answered? Because we definitely want to think about make sure we're being heard and our opinions are being taken into consideration. A huge part of medicine is what why we're just talking about this more and more in the last 10, 15 years is shared decision making. But that includes the part of the care team, listening to partners, children, getting everybody's invested in the treatment plan. Sure, as provider, I always tell my patients, I'm here to give you the information. You're here to ask me questions. You're the ultimate decider of what we can do in that clinic team. So please speak up. If you have concerns, write those down, because that just might not be something that is asked. The next group of medications, some people maybe, yep.
Hi, we did have one question about that last section.
Yeah, go for it. Yeah, go for it.
A gentleman or lady by the name of Jib Raw says, I think the carvedilol is causing me to keep a stuffy nose. I had an aortic dissection this past March. Was thinking about asking, can I go back to the benzapril amphophine combo? Does it really matter?
So I'm not sure what the combo would be. The benzapril will not keep the heart rate down. I'm not sure what the other, is it in the chat, Josh? Let me see if I can see it.
Oh, I can pass it into the chat. It'll be a little messy. Let me put this together for you.
Yeah. But yeah, if it seems it's not something I commonly see, but it doesn't hurt to ask. And right, we'd like to do like a timeline and kind of figure things out when things are seen. So while he's working on that, I'm going to keep going. But yeah, again, if you ever feel like side effects are changing, I think sometimes we get really stuck in these seasonal changes, having the air conditioning on, and sometimes we'll try some symptom management, especially if therapies are working, but really going back to your provider, it doesn't hurt to ask that question so they can get a sense of what's going on. But again, do not change I think the real important thing is do not change medications without talking to your provider so they can figure out what the best treatment plan is for you, and to see what to do. Yes, so benazepril and amlodipine, those are two different, that combination, those are two different blood pressure lowering medicines. Neither that combination does not include a beta blocker. So your provider, they're most likely going to want to keep you on carvedilol or try another one in that class because those other two drugs will not they're not there to keep the heart rate down. But definitely bring that up to them and see. They might even want to try a different medication in the beta blocker class for you because people do respond differently. So if people don't tolerate something like metoprolol or carvedilol, which the vast majority of people will do, sometimes it's just switching between the class, or we need another medication to help keep the heart rate controlled, especially some of our younger individuals. And Karen, that falls to you. I know somebody says, well, what do you consider young? I'm like, I think you're a 90-year-old. Like, listen, under 75 is young anymore to me.
That's great.
I know you're not near 75, but so we have two other medications, diltiazem and verapamil, that are in this class. Providers typically will try beta blockers first because these really can lower the heart rate a bit pronounced. My thing, nobody likes to as Karen knows, I'm always talking about poop in these conversations. I call myself the poop patrol at work. But I always say people don't like to talk about poop, pee, or sexual dysfunction with patients find it uncomfortable to pick up, providers find it uncomfortable to talk about. I'm happy to talk about it, but these medications can definitely cause constipation. And so if you are started on one of these medication classes, it's really important. We tend to have patients, if we do use it, starting something for constipation at the beginning when we're starting therapy. And then making sure, right, we know dental health regardless of this could potentially cause a side effect where the gums grow a lot. Dental health is such an important part of overall health and in different heart conditions, aortic conditions. So please see your dentist, even though they might be a little intimidating to you. Dental health is it's a gift to have. Don't even get me started on that, but it's a very important thing about your overall health. And so we have other calcium channel blockers. So the first two that I talked about in that last slide, they lower blood pressure, but while they are very helpful in lowering blood pressure, their job, we usually are picking those because we need something else to help lower heart rate. Calcium channel blocker is probably the one that's most commonly used that folks will see is amlodipine. It is my favorite drug for blood pressure if I don't have another reason to pick something else. Side effects are very minimal with this medication. There's no laboratory monitoring associated with it. There are some other products that are listed here. A lot of people will also use that third one listed called nifedipine. The one bullet's not showing on the screen, but certain formulations of nifedipine, you will see the tablet capsule come out in your stool. So don't be alarmed if you would look back and say, oh, there's like my medicine's in the toilet. That's just how the product is formulated. I have 3 sons, so you can imagine I get along very well talking about certain things here.
I have Crohn's disease, so it's a topic that's always on the table for me.
Yes. And so similar, I forgot to mention on the last slide, these medications can cause swelling in like your ankles, sometimes in the calves. It's not due to extra fluid. It's just they can cause swelling. And if that does occur, lowering the dose can help typically lessen or reduce that swelling. And then not common, but some people, just because these are open up the blood vessels pretty quickly, some of the medications in this class, and very well, they open up our blood vessels to lower our blood pressure. Some people will experience a little bit of headache and flushing when the medication is first started, but that should go away pretty quickly. Clonidine is another medication for blood pressure. It is a very effective medication. And sometimes we can also see some heart rate lowering. This medication is typically reserved when we have other medications that are being used and the blood pressure still not getting to where it needs to be. This tends to be used for our younger patients, typically less than 70 or so, just because this can make people feel really sluggish when they are on it. It can lower the heart rate. The nice thing with this medication, it does come in a patch formulation. So if people are added on this medication, because it is 3 times a day, once they find the dose, you can actually get it put on a patch, which can just, and it gets changed once a week. So that's a lot nicer than having to swallow a lot more pills per day. The side effects are listed here for you. So it can be very drying. Constipation can happen with this. If you wear contact lenses, they may feel a little bit different. So it's a very effective medication. And while these side effects can happen, they're not going to happen to everyone, but it's just something to be mindful of. I always say, making sure whenever you want to know medications about your side effects, please don't open up the labeling that you get at a pharmacy. There are reasons that all those things are in there. Talk to your pharmacist, talk to your nurse, your physician, nurse practitioner, please, because they can really give you the list of the ones that are most likely going to happen, the most serious ones, versus opening up that paper and you're like, whoa, this is pretty scary business.
I use clonidine. So yes, and I never read it, but I will tell you now, reading what you have here as a side effect, things are starting to seem a little bit, they're making more sense, because I have had severely dry eyes and I do not use contact lenses. I mean, they are very, very dry and very dry mouth. If anything, I'm intaking water like a crazy person. And I do experience a little bit of redness around where the patch was, not underneath, but around it. But I try to schedule my my MRIs around when I'm getting ready to take the patch off. So if I can get it on a date where I can then either it's in the very beginning of the week, so I can save it and then with Tagaderm put it back on so it stays on all week, because they're not, you only get 4 in a box. So you don't want to put it on and then have no way to re-stick it on. But they do come with extra larger bandages. They're almost waterproof, I guess. But I wear it's like a postage stamp. I wear it in the pool and it never comes off. I shower. It's not an issue, but it does need to come off if you're taking an MRI because it's got like a metallic background.
Mm-hmm. Yeah. And so, and if anybody has dry mouth, I'll just leave you this little pearl. Biotin products, which you can buy in your supermarkets. You can buy on Amazon. Biotin products, and it's like the brand. They're really good. Sometimes it's a matter of finding the one or ones that work for you. When like I use the there's like a topical one that a gel I put in my mouth. It took me a minute to get used to it, and then I'm like, ooh, this is a great product. And yeah, okay, I was going to pivot to something else, but I stayed where I was going, Karen. That should be good for me. The next medication class is talking about what are called our thiazides. So these are another.
I hate to bother you again, doctor.
Yeah, no, go for it.
Dean had a question about a tan, losartan specifically.
Sure, go
He's
ahead.
waking up coughing up lots of mucus from losartan, and his energy is still lower than he wants.
So I would say if you're waking up coughing up mucus and low energy, the likelihood that it is losartan is incredibly low. But definitely give your doctor a ring. If people cough, it's from lisinopril and it's a dry cough, it's not going to be a productive cough. None of these medications will give you a productive cough. So definitely talk to your provider. You may even want to start with like your primary care doctor, because there could be a multitude of things. Yeah, and the thing that's really tough is when we talk about a lot of the side effects that can come with high blood pressure medications, they are not very specific, right? So when somebody comes in, when they come into the hospital and they say, I'm really feeling tired, there's a lot of bases we have to cover to make sure we're looking at things. But I would definitely schedule a time with your primary care provider to get a sense of what is going on. If you recently would have stopped smoking, congrats to you. Smoking is the hardest thing for people to quit. Sometimes as the lungs start getting better, you start to get you'll see some changes in cough and sputum production, and that's kind of part of the healing process of the lungs. But even if you just stop smoking, I still want you to get checked by your provider so they can get a sense of what may be going on. And maybe that's just recovery from if you had surgery. But I really want you to just get checked out and check in, because if anything, they're helping. I think sometimes we don't always do the best with our patients of setting expectations about what the recovery period looks like. So please do get checked out with that. You got anything more for me there, Josh?
No, ma'am. That was the one that floated in. I was looking through the slides and noticed that we had just passed it, so I wanted to jump in before we push too far in. On to thiazides.
Thanks. So these medications, again, have been around for forever and a day. So these medications are once daily. They're very good for lowering blood pressure. So they can be used in combination with amlodipine or those ACE inhibitors or ARBs. The important thing with these things is, one, if you have gout and you get a gout flare, please make sure anytime, if you have gout and you have a flare in gout, please get seen as quickly as possible, notify your provider as quickly as possible. The earlier you are in to get treatment, if you do have gout, the better. These medications will not in themselves are going to really cause gout for people. It's if you just have underlying gout, sometimes it could precipitate it happening again. These medications, because of a component of the medications, make you more skin sensitive. We should all be wearing sunscreen all the time now, as we know what's happening with the ozone layer, but especially if you're on any medications that are making you more sun sensitive, people are burning more than they ever have. So be mindful, if you are on these, your pharmacist should be sticking that little sticker on there, like wear sunscreen. Please do your due diligence, even if you're like, oh, it's a cold day, the sky is cloudy. I think we get tricked into that sometimes.
Well, and we were just talking before we came live, and I'd mentioned doxycycline, antibiotic, just like tetracycline. These are just things that I grew up with, knowing that you want to avoid the sun or be slathered and lathered, right? And I had mentioned I hadn't even been in the sun. This was sunlight coming into the car that was direct on me, on my arms for a long period of time. I was driving a long distance. And the problem with that photosensitivity is it can cause a really nasty reaction. This isn't just like you're going to get a sunburn and that's it. I could have taken a little sunburn. I would have rathered a sunburn instead of welts and bumps, and it's just gross. And then it made my knuckles swell. It was very bad. And I just feel moving forward, because that never happened to me in my life on that antibiotic ever. I'm just going to I just feel like I should have sunscreen on all the time. I don't care what time of year it is, because these medications, I'm just nervous I'm going to eventually metabolize them differently or something's going to happen, and I never want this again. So I do take, furosemide, and I don't see it on here, so I don't know if it's one of these, but I'm telling you, sunscreen, just make it be your moisturizer, because it's not worth it. Trust me.
Yeah, it's a really good just general, kind of going along with our dental care, there's more and more push from our dermatologists and stuff. We really need to be, and if you don't, even if you have hair covering the scalp, if you have a part, wearing a hat for folks who may have very thin hair or no hair to on their head, please making sure, right, because that's where the sun is hitting, covering up with sunscreen. Don't worry about if you look like you got thick amount of sunscreen on your head. You'll be happy when you don't get sunburn and you don't get, and preventing sun cancer is the most important there.
Exactly.
These are my favorite medications. I have a couple tattoos, and my friends tell me I should get the molecular structures of these tattooed on me because I love them so much. So these medications have a few different roles. So there's 2 medications in this class called spironolactone, and the other one is a eplerenone. So some people will call the group aldosterone antagonists. Some call it, we have other different names. But if you're on one of these 2 medications, for some people, we add this medication on top of other classes that we already discussed for hard to control blood pressure. For other people, we may add it on for different things related to other heart conditions. And they've been shown to be very effective in, if you also have heart failure, lowering the risk of death. And then in hard to control blood pressure, this is it is magical to see the change that it can happen. If you are on this, I even caution you, if you're on other medications, is recently using salt substitutes. Be mindful of that. Potassium-rich diet is good, but that is when we're eating naturally, potassium naturally in our foods, and that comes in our fruits and vegetables. Salt substitutes that look like table salt are high in potassium. And so shaking that on can quickly raise your potassium levels, and too high potassium levels can be very dangerous. So we tell people to stay away from these, and that if we need your potassium to increase for some reason, we'll give you a medication to do that. These substitutes worry me when people are on medications that can increase potassium levels, or salt substitutes. If you are on spironolactone, males and females can get breast tenderness. Males can see growth of the breast tissue. I will tell you, many male patients that we have seen feel uncomfortable bringing that up. So please do not hesitate to bring that up. Females, if you are still menstruating, this can cause menstrual irregularities. But its cousin, eplerenone, does not have those side effects. So if those side effects do develop, they'll switch you over. The second drug listed there is in generic formulation, but it is still much more expensive. Spironolactone is one of the oldest drugs on the market. And just like some other medications, you'll monitor kidney function and blood pressure with this. And then the water pills, that's what the loop diuretics, I always tell patients I never need to tell them which one's their water pill because they know. So these are listed here for you. Furosemide, bumetanide, and torsemide. So these are the medications that are used to help get extra fluid off, because for whatever condition, there's several different conditions that can make the body hold on to extra fluid. These medications are helping get that off. It's really to be mindful. I'll hear people say, well, take this in the morning. Well, what if you work overnight, right? So it's really to be mindful when you're determining, you'll figure out for yourself when you're taking this medication in the day, its job is to get the fluid off. So if you got a doctor's appointment first thing in the morning, you may work with your doctor and say, you know what? Is it all right if is it okay if I'm going out for the morning for some doctor's visits to wait till I get home? So have that conversation with the provider, and working around figuring out through your schedule. The shortest effect they give is like 6 hours up to 8-10 hours. So they're not lasting you all day, but please do not take them before you go to sleep because you will not sleep.
You are 100% right. I cannot take them if I have a long drive. One time only did I take it when I was getting my hair dyed and a keratin treatment, which if you've ever had that, they're constantly working on your hair to put a keratin treatment in. And I literally had to go to the bathroom every 10 minutes on the hour. And it was good. I mean, it was wonderful. This wasn't like you went and it was like tinkle, tinkle. We're talking.
No, you really were.
I was fully going to the bathroom. As soon as the drink's going in, it literally just came straight out. There's just no way. I mean, you have to go so bad that you're much better off just taking it when you know you're going to not have to be in a situation where you can't easily access the bathroom. I just feel like it's like a colonoscopy, just a different area, because you really do. You have to go to the bathroom so badly, but it's so effective. And I think a lot of women, unfortunately, look at a diuretic as a way to play with their mind and weigh one thing one day and wake up and you could be 3 pounds less the next day. And it was just water weight. It's probably just going to come back, but don't abuse it thinking this is a way to lose weight, because it's definitely not.
Yeah, absolutely. So these things, that's a great point, because we will hear some people say, well, I want to be down to this weight. Overtaking a loop diuretic medication in this class, you can cause kidney failure. Being mindful if you're out in the heat, making sure you're drinking an adequate amount of water on a daily basis, because if your kidneys are working the right way and you're taking more water in on a given day, your body is going to adjust to that to get the extra water out when you take the dose. So when people are on this, you want to check your weight every day. One, this to see if your weight is not going, staying about the same. But if you're starting to see your weight drop pretty quickly, your weight is continually going down, that is a sign that too much fluid is coming off. So when people are on a lot of other medications and blood pressures go down and they're getting dizzy and lightheaded, we often have to think about that. Are we giving too much water pill to that individual? And so that's our job as a provider, to help tease out those nuances. But keeping a track of your weight, same time every day, get up, go to the bathroom, be in your birthday suit, in your pajamas, but checking your weight in the same level of dress, same time of day. For that, and keeping a log of that, because I eat the same thing for breakfast every day. I have to really think what I ate for lunch today, because that's not always the same. And so I want to be mindful of your time. We have a couple other things I just want to get to. Hydralazine is another blood pressure lowering medication. This is a 3 times a day medication. Please be honest if you're with your provider and you're on a medication that you can't take 3 times a day. I am a pharmacist. I am married to a pharmacist. Karen knows I have pharmacist friends. We have a mutual friend who is a pharmacist. And one of them, most pharmacists I know, we struggle if we had to take a 3 times a day medication. That's really hard to figure out in your working day or whatever else is going on in your life. So this has to be 3 times a day. If you can't do 3 times a day, your pharmacist can work with you to figure out a good habit regimen. But if you think it's going to be really hard, please be straightforward with your provider. We love it when our patient's like, I can't do twice a day. Then I got to figure out what's the best regimen for you, so that I can make sure we're going to have success with the regimen and you're going to be able to do it without stressing you out. As Karen alluded to a little bit earlier today, we talked about tobacco cessation. So not only smoking cessation, but we have chewing products, other forms of tobacco. When we think about tobacco cessation and help people quit, as I've seen people on all kinds of substances. Tobacco is nicotine. The tobacco products are the hardest to quit. It takes people a lot of tries. So if you quit and you pick it back up, there's a wealth of resources in this country of people who can help you and will support you through this. The 1-800-QUIT-NOW line is fantastic. That is through the Center of Disease Control, and each state gets money to help support that. There's text messaging options with that as well. We have a lot of great products that are available, medications to help you quit. The best success is with a medication or nicotine replacement products such as the patch, and counseling. Please do not use e-cigarettes. Do not vape to help quit smoking. We're finding out more and more evidence how bad they are for you. And if you use those products, to help you quit smoking, you're going to be addicted to those. So we have a lot of great options that are out there. Depending what state you are in, many states pharmacists under law are able to prescribe tobacco cessation therapy, so giving you more quick access to tobacco cessation products. But I cannot encourage you more to call that 1-800-QUIT now, because they can get many of the programs can get patches, lozenges. They can get you hooked up with resources really quickly. And again, if you're having a hard time quitting, please, when you're ready to quit, that's when you're going to be the most successful. And find a provider who's really going to help you work through that. This is one of the most important, in addition to keeping your blood pressure low, tobacco cessation is one of the most important things for a healthy aorta, healthy blood vessels throughout the body. Medication adherence. So when we're talking about taking your medications, I have no doubt you walk out, you come in, you give a new diagnosis of aortic disease, some form of aortic disease, you come out, you probably got 3 to 4 new medications that you're walking out of the hospital with, or you're walking out of your doctor's office with. That can be very overwhelming. Again, I think we don't talk enough about how that can take a toll on us mentally, emotionally, when those things happening. You just have to find what works for you. So sometimes it's trial and error, but have somebody. One of my friends was over here, and I was trying to figure a better way to remember my kids' medication in the morning. She's like, "How about we do this?" I'm like, "Oh yes, that's what we're gonna do. Let's try that out." And guess what? It works, because she's been my friend forever, and she knew me better than myself. So finding that, but you want to take your medications at the same time each day. If a medication is listed for twice daily, we want to separate that by about 12 hours. If it's 3 times. I have
a question real quick about that. And I know 3 times would be every 8. Okay. So one of the things that we don't talk about enough in the community is how long it takes for some of these medications to take effect. I think the misnomer is people believe it works like a Tylenol. In 20 minutes to a half hour, it's going to work. And that is not the case with a lot of these medications. But what I understand is some could take 2 hours. I thought I heard somewhere that some can take maybe up to 4 hours. And that's part of why it's so important to take them at the same time every day. And when you say that, do you mean if you're taking them twice a day, and you're going to bed around 10 o'clock at night and you're waking up around 8:30, are you waiting until 10 a.m. because you know you're going to take it at 10 p.m.? Is it have to be exact, or is there play? Like, yes, I got up today at 8, so I'll take it. But tomorrow I get up at 10, so then I'll take it. I used to set my alarm in the beginning. Now I'm just, okay, it's the morning, I'm brushing my teeth, I take it. And I might be within a 2-hour window, but I can usually gauge, I know what time I took it, so I'll stick around that time before I go to bed.
Yeah, so it's really important to try to be as consistent as possible on a day-to-day basis, because what happened, there's some wiggle room about that 12, or if it's twice a day, that 12-hour period. And so, when when we're thinking about medications here and when they kick in, it's really only the water pills. They're kicking in within 30 minutes to the hour. But these other medications, they get to what we call, a term we use in pharmacy, is in steady state. So when you're taking them on a regular basis, they have a nice, pretty much consistent level throughout your body. And so you're kind of replenishing that level at that 12-hour mark. So you want to keep that level you want to keep it. Yes, there's some ups and downs with it, but trying to keep it as close as possible. And I always say with the blood pressure medications, if you take a medication too close together, you get 2 doses 6 hours apart when it's supposed to be 12 hours apart, your blood pressure could really drop because now you have too much medication on board. And then you could not have a drug as much as you can. But you really have to work it with your lifestyle, because at the end of the day, the only way that it's going to work is for your lifestyle. The one that I really try, I hone into people, the ones the most important. I mean, all medications are important to separate them out, but really making sure, and if doing something, let me back up. If doing something twice a day is tough, just tell your provider, because a lot of times, a lot of medications have a once daily. When we're thinking about older medication classes, which fortunately we have a lot of them when it comes to that heart, aortic disease, cardiac disease, is that we can get people on those once daily things. But yeah, using the alarm is a great tool for people. And there's some medications that are going to be more sensitive than others, but I just like the general rule of, because then you can't keep track of all of that, is trying to keep as close as you can. But again, it's going to work. You have to work with your schedule. Talk to your provider, because I have some people who are like, it's going to be 9 and it's going to be 7. And that's the only way it's going to be working. Well, then guess what? If 9 a.m. and 7 a.m. is the only way it's going to work, then this is how we're going to do it.
So if you take more than one medication, let's say, for example, just making it up, no, I'm not, you take a bistolic in the morning, you take losartan in the morning, you take other drugs, and flecainide, throw in just a bunch. There's just a lot of things that go in the morning, fenofibrate. Let's say you've got 6 different medications separate from your B12, right? Or a Claritin. Do you just pop them all at the same time, or I've always wondered this, because that's what I do. And then I sit and wonder, how are they all mixing and churning in my tummy? And how do they all know how to work if I've consumed them all at the exact same time? Is it recommended that maybe you just give it 5 minutes, or you literally can just throw them in your hand and chuck them down?
Yes, there's some medication. So, can you take all medications at once? There are certain medications that have to be separated from other ones. So that's like things for thyroid disease, some of our stomach medications. So unless you're getting a specific education on that from, please do read the labeling that you get about and watching on your bottle. Unless you're getting those specific things to separate out, you can take them all at once. I do. Okay. If you are taking like a multivitamin, a calcium supplement, that please make sure your providers know all about like any vitamins you may take, right? Like if you're taking a calcium supplement, because some of them can bind to certain drugs. So we want to make sure that we are being mindful of that. Somebody opened my door. Wasn't the dog, because then he would have barreled in here. So these are just some great resources here for you. I always say, if you want to go for, if you want to get disease state medication information, go to the websites where there are big cancer institutions, because I know this might sound silly, but cancer institutions with big cancer centers have lots of money. And they have wonderful resources. So the Mayo Clinic, Sloan Kettering, Johns Hopkins, that's real. You see a lot of duplicity from site to site, but if it's a hospital name you recognize, they tend to have really great educational materials on their websites, because they have the resources to be able to provide that. And that's where I'll pull a lot of my information for patients as well. So I want to be mindful of your time. And I also have 3 kids who just started we just started school here in our county. So I'll take about 5 more minutes. Any questions folks may have, you can always send your messages to Karen. She knows how to get to me, and she can send them to me, and I can always follow up with you as well.
I see 2 more here in the chat, at least comments, if not, and a question. So from Elena, she recently had to go to the ER because she wasn't, for whatever reason, her body was not responding to her medications, and they needed to assist her in helping her lower her blood pressure, and they actually gave her clonidine. So I don't know why the body all of a sudden decides to not want to lower when you take these meds. For me, I'm missing 6 feet of intestine around the small intestine, around the ileum. So I know that that's an area where a lot of absorption might occur. So sometimes when I take my meds, they work really well and I'm very low, and other times they just don't work. So I knew having the clonidine patch at least gave me something that it wasn't going to be impacted by the lack of intestine. So it was kind of like this hum of a constant release of medication. Any thoughts on why blood pressure doesn't work for some people at certain times?
Yeah, so so one thing can be about the timing of the medications. Dietary indiscretion, right? So you might maybe you eat low sodium all the time. Sodium intake can have a massive response on blood pressure, especially as we get older. So once we get, so maybe you had a change in diet. The other thing we tell people is, once you see a high number, when you check your blood pressure, you should check it once and then a second time a minute or 2 later. If those numbers are higher than usual and you keep checking them, sometimes you're getting anxious and they're going up on you. And so it's really important too at home, making sure you have an accurate blood pressure cuff. But, it's missing medications, dietary changes, but there's different other things can happen as well. And sometimes it's just finding the right regimen that's going to work for an individual to get them controlled on their blood pressure. And so a lot of people, like I said in the beginning, are often going to need 2 or more medications, and also be mindful of, I am, not a fan of the supplement industry. There's not a lot of good data out there to support any of those, and we never know what's in those products. Some of our cough and cold medications, so just being mindful of those as well. Our cough and cold medications usually don't give a big upswing in blood pressure, but just to be mindful of those things as well. Higher alcohol intake, there's a lot of different things that can acutely make the blood pressure worse. And sometimes we don't have 100% reason, but pain can make it worse. There's a lot of different reasons. And when somebody comes in with higher than usual blood pressures, it's our job to do the sleuthing on the inpatient side or in the clinic setting to figure out what might be going on, versus your important role is let's go in and get some treatment and let's figure out what is happening.
She does say that the 12-hour, if you have to take something twice a day, I don't think she was doing it every 12. Instead, she was doing it more like every 8. She was doing it 8:30 and then 4:30, even though her blood pressure tends to creep up higher in the afternoon. So that's very interesting to me. And I'm not a doctor by any stretch, but I'm very fascinated by people's stories. And to me, it sounds like it might be a medication choice and it might need an extra little boost or like a little amlodipine or something. So I think what you're saying makes a lot of sense. You need to chart this for a while and see what's happening at the times of the day and what you're doing. Of course, don't take your blood pressure after you just walked in the door. Let your body relax, and don't take it after you ate a big heavy meal because your body's working hard to digest. But pick a nice relaxed time and take it. And that's what your cardiologist should be doing, is just kind of reading this and studying it and coming up like a chemist. What can we do? And then would work with you on this. But there was one more question. Oh, sorry. Go ahead.
I'm going to drop the things that we need to do in this chat, so that you guys can see that the correct way to measure the blood pressure.
Perfect.
The other thing to do is talk to your provider how many times you need to check per day. There are also sometimes people we can get for folks if we're seeing a lot of variability in the day, is adjusting when things are taken. Also, there's some 24-hour blood pressure monitors that your provider can get for you if they're having challenges.
Yes, and those are fun because they just start out of nowhere and you have to just stop what you're doing. So it's challenging when you're driving because you really need to relax that arm as best as you can when it decides to go off. But we did get in one other question before we go. And it's interesting, we didn't talk about this time, but I will get it from you the next time, was blood thinners and talking about how, I really want to understand Advil and why you can't be on it when you're on Eliquis. Not today, but these are some of my questions in the future and the effects as we, go into cold and flu season. And we can maybe talk with you sometime after the first of what Sudafed. I am told all the time, no to Sudafed. How I want to just take it, but I'm told no. Why certain cold medications are no, and they prefer Corseed and HBP. So I look forward to having you on again, and let's talk about some of that stuff. But the other question came in from LM San again, and I said, does metoprolol have any connection to causing gout? Never had gout before, and never had it prior to or before surgery, and was just wondering if it's related.
Yeah, great question. I'm sorry you have gout. I just see it happen, and it seems very unpleasant. No, there's no connection to metoprolol with it. There are some people are just prone to gout. It's hard to say what other medications you would have been giving during surgery, but when we think about the most common thing that can cause gout is if we take too much fluid off of a person, if we're taking a lot of extra fluid off at a time, but there's a lot of other things. The diet is a big reason that people get gout flares. There's certain foods that people can eat, certain meats, high fructose drinks. There's a lot of dietary reasons in people who are at risk for gout. Food is the most common trigger of gout.
Okay.
Mm-hmm.
All right.
Or one of the most common triggers, I should say. Yeah.
Well, he said, oh, the person says
Painful. That's what I hear. I understand,
Yeah.
and I see it, and I'm like, oh,
Yeah.
don't give that to me.
Don't give it to me. Hey, but neither are gallstones. They're not pleasant either. Kidney
Nothing's fun.
stones. No, and you know what? So, okay, Lasix, furosemide, supposed to take it every day. I can't do it. One of my kidneys really starts to get impacted if it's an everyday occurrence. After about day 2, it starts to feel like it's like it's just drawing sensation, like it's overworking.
Yeah, and I think just it's important for folks to use caution because everybody is so different.
Yeah.
And how we respond to medication. Some people need 2 doses of a water pill in a day. Some people need it a couple of days a week. So everybody is so different in how they're going to respond to a medication. But again, anytime you have any concerns, there's a lot of different sleuthing that we can do on our side of things as providers to kind of figure out what could be the cause, what may be the cause, who do we have to refer you on to, and that kind of stuff. Well, it was a pleasure being here today.
I'm so happy that you joined us. You're our very first guest for Aortic Disease Awareness Month in September. So it's always wonderful. And again, let's talk maybe January, I think might be nice. And let's really share with everybody a little bit more about some of the arrhythmia medications and why this arrhythmia, why would they maybe be prescribed, because we haven't talked about that. Pacemaker potential issues, what you might go on if you have mechanical, would you be on anything if you were bioprosthetic valve? And let's talk about the cold and flu season and vaccines and just what we can do, because these things impact us greatly. People don't realize how hard the heart works to rid ourselves of any of these infections. So let's definitely chat in January. And now you have to go and deal with 3 kiddos and say, how was your first day at school? Did you learn anything? And they're going to say, no, nothing.
And thank you for reminding me. My vaccines I didn't pull up. Please, flu season has not really seemed to leave us, but flu shots are going to be coming out. Please make sure you get your annual influenza vaccine. We know that's so important for this population and a lot of chronic conditions, as well as when the next COVID booster comes out as well. An RSV vaccine if you are due for it. Please, please, please get those. If you have any questions about your vaccine, please talk getting vaccinated, concerns with getting vaccinated. Please talk to your healthcare provider so we can provide you with the most accurate information to keep you safe.
Wonderful.
Thanks, Sarah.
Thank you. Thanks, Kristin. All right. Thank you, everybody. Don't forget to click like, click subscribe, click the bell, and share it, because I guarantee you someone will find this information very helpful. And thank you again. We will see you soon at our next event, which is tomorrow at 3 p.m. Have a great night, everybody. Take care. Bye, Kristin.
Have a good night, guys.